Thank you for joining us for our session on active surveillance today. Now, please join me in welcoming Dr. Jason Hafron. He is the Chief Medical Officer and Medical Director of Clinical Research at the Michigan Institute of Urology. Dr. Hafron is a professor of urology at the William Beaumont School of Medicine, Oakland University in Michigan. Thank you, Dr. Hafron, for joining us today. It's my pleasure to hand it over to you.
Thank you so much, Jeremy, for this opportunity to speak on behalf of ZERO. ZERO is the premier patient advocacy, patient support organization throughout the United States. So really a privilege and an honor. Today, I'm going to talk all about active surveillance. As Jeremy said, my name is Jason Hafron. I just got to get there it is. I work in Michigan. I'm a urologic oncologist. I specialize in prostate cancer, and I hopefully will give you a lot of good information to better understand active surveillance. So introduction, active surveillance, just what is it? Active surveillance of prostate cancer is a management strategy that involves closely monitoring prostate cancer without immediate treatment. It is typically recommended for men with low-risk prostate cancer that is unlikely to spread or unlikely to cause harm in the near future. So what are the benefits of active surveillance with prostate cancer? Why would someone want to do that? The reality is it avoids unnecessary treatment and its potential side effects. It does provide close monitoring, which gives peace of mind so that we're not just letting these patients go. You still have prostate cancer and we'll still monitor you so that you can sleep at night and rest easily knowing that someone is monitoring your prostate cancer. And with active surveillance or the protocols that we follow, it allows for early detection of any progression or changes in the prostate cancer. So if we need to treat the prostate, we can always treat it because we are, again, following our patients very closely. The basis for active surveillance is based on the PROTECT trial. This trial was published recently in the New England Journal, and it was done in the UK, and it looked at about 1,600 men with low-risk prostate cancer. They then took the 1,600 men and divided them equally between active surveillance, prostatectomy, or radiation therapy. And what's interesting is that they found is that in 15 years of follow-up, which is a very long time for prostate cancer trials, there was a very low risk of dying of prostate cancer. But what's important and why we do active surveillance is based on this trial and many other trials done in this space is that they're similarly effective. It doesn't matter if you had surgery. It doesn't matter if you had radiation or we watched it and did nothing. All the patients did equally the same. Okay, and that's the basis of why, as a urologist, we can comfortably follow prostate cancer. Additionally, if we follow prostate cancer, we can avoid the side effects. Anything we do, whether it's surgery, radiation, freezing the prostate, there's always going to be side effects, except for active surveillance. We can avoid erectile dysfunction. We can avoid urinary leakage and potentially even rectal irritation. So here in Michigan, Jeremy and I were talking about this just before we started. We have a collaborative called the Music Collaborative, and it's a collection of over 300 urologists throughout the state of Michigan. And our goal in music is to be #1 in prostate cancer in the country. About 10 or 11 years ago, we committed to improving the care or improving the utilization of active surveillance. If you look at the graph on the right, the red line there is when we started, about 2014, and about 20% of the patients in Michigan were actually going on to active surveillance protocol. The national average was just about 20%. To get to that point, or to get to where we are today, what you can see is, I'll show you in the next slide, is over 90% of the patients in Michigan go on active surveillance with prostate cancer. We developed a roadmap for the management of men with favorable risk prostate cancer. And today what I'm going to highlight is this roadmap, kind of a look behind the curtain of how, as urologists, we decide and what we discuss with the patients on who should go on active surveillance, but also how we manage those patients on active surveillance. And this is our data that was just recently released a few months ago, is that and this is not even completely up to date, but in Michigan, through our collaborative called Music, we have the highest rates of active surveillance in the world. 90% of the patients with low-risk prostate cancer in the state of Michigan are going on active surveillance. And I think a lot of that has to do with the roadmap that I'm going to talk to you about today. Also, what we've seen recently is that patients with intermediate risk prostate cancer, or Gleason 3+4 = 7 prostate cancer, about a third of those patients are being placed on active surveillance. So over time, we've seen the expansion of active surveillance in the low risk, but also in the intermediate risk patient population, which is quite interesting. So what is the roadmap? How do we do it? How did we become so successful in Michigan in utilizing active surveillance for appropriate patients? We divided it up into 2 stages. One is the consideration phase, the steps that we take as urologists, and which I'll explain to you as a patient when considering active surveillance. And then the second part is the surveillance. We've developed a roadmap on how patients should be followed, and we educate our partners and other urologists throughout the state of Michigan. And then based on the data that I've shown and will show you, we've been quite successful. So let's talk about the consideration phase. And we've identified 3 steps that are critical to evaluating whether a patient qualifies for active surveillance. Step 1 is estimate a life expectancy. Step 2 is determine the appropriateness of active surveillance based on the Music criteria, the criteria we developed. I'll show you this in a second. And then step 3 is confirmatory testing. So we've established this very specific, clear roadmap on how to manage and identify patients for active surveillance. So step 1 is estimate life expectancy. So what we need to look at is the patient going to live long enough where active surveillance is indicated? Because there's another option besides active surveillance, which is called watchful waiting. Watchful waiting is usually for older men greater than 80 or have a limited life expectancy. To be honest with you, estimating life expectancy as a physician can be very tricky. But what we do have is a lot of data based on age, based on comorbidities, where we can generally estimate a patient's life expectancy. Generally, what we like to see is at least a 10-year life expectancy. So without getting into very detail, a lot of detail, average patient that's 64 to 65 years old has about a 20-year life expectancy. A patient that's 79 to 80 years old has an average life expectancy of about 10 years. Once you start getting above 80, the life expectancy starts to go below that 10 years. And when that number goes below 10 years, we would probably consider a patient for watchful waiting, which is essentially less intense follow-up for active surveillance. These are generalized numbers. Every patient's different. I have 80-year-olds in my practice that are probably in better shape than me, that work out and can run longer than I can. So it's generalizations. All of the life expectancy has to be adapted to each individual patient. The second phase is to determine the appropriateness for active surveillance based on our Music criteria. And that's going to be the Gleason grade and the tumor volume. Gleason grade is a scoring system that we use to identify how good or bad your prostate cancer is. 6 is the best. That's a 3+3. 10 is the worst. To be considered for active surveillance, you need to be a 6 or possibly a 3+4 or Gleason 7. When you look at the table on the slide, you'll see that if you're a low volume Gleason 6, meaning you have 1 or 2 cores of your biopsy that are positive, you should strongly consider active surveillance. If you have an intermediate volume Gleason 6, 1 or 2 cores positive, 3 to 5 cores positive, or more volume of cancer in each of those cores, you still should strongly consider active surveillance. High volume Gleason 6, we would say consider active surveillance or maybe uncertain. In my practice, generally speaking, most Gleason 6, whether they're low volume or high volume, most of those patients will go on active surveillance. We also consider active surveillance for Gleason 3 plus 4 equals 7. Those patients usually have to have low volume disease or can be considered unfavorable risk. So these are the Gleason grades, and the number of cores is that we consider based on the pathology or based on the biopsy whether the patient qualifies for active surveillance. Then what we like to do afterwards is confirmatory testing. We possibly may repeat the biopsy within 6 months. We may repeat or order an MRI to further evaluate the risk. Or a lot of times what we'll use is genomic testing. And genomic testing is where we take, and here are the 4 companies that offer genomic testing, is we'll take a little piece of that tissue, except for Artera, which is AI-based, but we'll reevaluate the patient's individual tumor to get another risk assessment, how good or bad their cancer is. And if the genomic classifier, it shows that the patient's truly low risk, it's another layer of certainty that we don't need to intervene, we don't need to do surgery, we don't need to do radiation for this patient. So the bottom line here is how we decide on active surveillance is we look at the Gleason grade, we look at the tumor volume, how many cores. We typically use a genomic classifier. We'll use an MRI as well. And then we sit down with the patient and his family and go over all this data and make a shared decision on what's best for the patient. Based on these parameters, typically we'll identify an excellent candidate or a patient that would do well with active surveillance. So once we've decided they're done the consideration phase and we put them on active surveillance, the next phase is the surveillance phase. And that's the roadmap of how to actually do active surveillance. We've decided that they don't need to be treated, but how are we going to actively survey or follow these patients over time? Generally speaking, is we check a PSA every 6 to 12 months. We do digital rectal exams usually every 6 to 12 months, MRI scans roughly annually, and that we will rebiopsy definitely within 1 year and every 3 to 5 years. What's interesting is we recently reviewed this data and we see that urologists have a lot of heterogeneity or differences on how they follow the patient, and the focus for music in the coming years will be to improve the surveillance phase or to better identify patients, the frequency of MRI imaging, the frequency of biopsying, so that we can better follow these patients. The question that we get asked a lot in clinic is what % of patients actually need treatment? They go on active surveillance, they're being followed, but what's the chance that if I go on active surveillance, I might need surgery, radiation, whatever, down the road? And this is consistent with most published large series, is that 25% of the patients after 5 years will require treatment. So 1 out of 4 of patients will get surgery, radiation, or some form of treatment. It's less than 10% in 1 year. At 3 years, it's 16%. So a lot of times when I talk to patients and I consult patients, I say, right now you don't need treatment based on your biology, based on your pathology, but down the road you might need it, and it's about a 25% risk over a 5-year period. The other question that we get is, if I'm wait on my cancer, I don't treat it right away, am I going to jeopardize my life? Am I going to jeopardize any future interventions? Or am I going to put myself, in a worse situation? The reality is we don't really see that. And this is data from music, our statewide collaborative, that looked at patients that underwent immediate surgery versus delayed surgery or surgery after being on active surveillance. And then we looked at the percentage of patients that recurred after surgery, whether they had it right away or they delayed their therapy. And what we found is that the rate of recurrence in those that delayed their therapy that went on active surveillance was 16%. Those that underwent immediate surgery had a recurrence rate of 12%. A 4% difference, not that big of a difference, so that we could potentially, and we're comfortable offering active surveillance, because if there's an intervention required, we're not seeing significant differences in outcomes. So, when do we decide that a patient needs to go to treatment while on active surveillance? The number one or the best indicator is a change in their biopsy, a progression of tumor burden, or really a change in their Gleason score. If their MRI changes, if they develop a PIRADS 4 or 5 lesion, or a change in the lesion that we've been following, that would be a trigger to progress. A genomic test, if at genomic test we see an upstaging or more aggressive disease than we saw initially, or patient preference. Sometimes patients, get frustrated, they get overwhelmed, or it's kind of like, too heavy, or not allowing them to sleep at night, watching their cancer. They will frequently just request, doctor, I've had enough. I know I just want to, I'm sick of the biopsies, I'm sick of the MRIs, I just want to go ahead and treatment. And when you look at patients that, transition to treatment, a lot of times it's really what, personal reasons does make up a significant part. So here's a study of patients that were on active surveillance that went to treatment. Why did they go to treatment? 23% of them went for a medical or personal reason. 69% transitioned to treatment for medical reasons, and then 8% was a personal reason. So the medical reasons that the patients, stated in this study was half of them, 45 or almost half, 45% of them said the doctor said the cancer got worse. Half of them said that the Gleason score got worse, a change in digital rectal exam, increase in volume on repeat biopsy, or an increase in PSA. PSA, is not a great marker for active surveillance, as we use it all the time. Really, our triggers for treatment should be based on an MRI or a biopsy change. And then personal reasons, sometimes patients just, like I said, get sick of it. I just decided I wanted to get treated. It allowed me to sleep at night, allowed me not to think about it as much. That does come up frequently. And if patients are getting consumed or overwhelmed by the thought of having a cancer that's being monitored, sometimes we do recommend treatment. So even if the biology says it doesn't need to be treated, we have to treat the patient. And if the patient is having issues with this, we'll go ahead and treat them, which does come up at certain time, frequently within patient care. So my take-home points, and then we'll have 10 minutes to get a good discussion, are properly staged prostate cancer shows predictable behavior. We've seen it in multiple trials. Whether you watch it, resect it, remove it, radiate it, freeze it, patients in low-risk prostate cancer generally do the same. So if you do the same with no treatment and active treatment, why would you subject yourself to the side effects associated with any prostate cancer treatment? Following an established protocol or the roadmap that we've developed in Michigan makes active surveillance easy. The patient will know what testing is coming for the next 5 years. It makes the physician job easy, so that we know exactly what to do, when to order a blood test, when to check an MRI. And the key here is that if we follow patients closely, if we keep them on an active surveillance protocol, we can maintain a high quality of life, so patients throughout their 50s, 60s, 70s can avoid urinary incontinence, they can avoid sexual dysfunction, or even sometimes rectal discomfort. So for those reasons, active surveillance is a great option in the appropriately selected patient. So thank you very much. I think we're going to open this up to questions throughout the chat. I'm going to, Jeremy, do you want to run through some of these questions?
Yes, thank you so much for that, Dr. Hafron. That was great information. And as you mentioned, you coming from Michigan and music, you're the expert in this, as you all are leading the pack here. Let me see what questions we've got coming in. It just looks like I think you might have covered this, but kind of the PSA consideration, I think in terms of that level, and then the active surveillance. Can you just kind of rehash
Yeah.
that again?
Yeah, so we check PSA every 6 to 12 months for patients on active surveillance. I think that's critical. The problem with PSA, it's not a perfect test, okay? It's very rare that we would, initiate therapy for a PSA change. I think the way that we look at PSA is that if there's a significant rise in PSA, that's a trigger to check an MRI. That may be a trigger to check a biopsy. And based on the MRI or the biopsy, that's a better step or trigger to move to active treatment. So PSA, even though it's not perfect, it kind of tells us what additional evaluations or may increase the evaluations, increase the frequency of the evaluations if needed. But I think the key message here, Jeremy, is that rarely would a PSA change alone initiate treatment or transition from active surveillance to treatment.
Okay, that's great. Always good to just kind of reiterate this, right? So appreciate that. Um, Somebody is asking about PSA density. So maybe you can kind of define that for the group just to make sure everyone knows what we're talking about when we say PSA density, and is that a more reliable indicator?
Yeah, great question. So let me explain PSA density. PSA density is a ratio. It's basically we put the total PSA on the numerator at the top, and then the denominator is the volume of the prostate based on ultrasound or MRI imaging, and it spits out a number or ratio. When patients have an elevated PSA density, whether it could, sometimes people use a cutoff of 0.1. I like to use 0.15 and above. They are at increased risk for progression, or it's a sign of more aggressive prostate cancer. PSA density is a good marker. It's been every time we tested in any group or any series, it always is predictive. So to whoever asked that question, that's a great question. I probably should add that to the slide deck as a predictive tool. Me personally, I like to use the genomic classifiers a
Mhm.
lot, but PSA density is a great marker that is relatively inexpensive and easy to get.
Okay, thank you for that. Next question is and of course this always depends on the individual, but what is the risk of grade 1 Gleason score 6 prostate cancer progressing to other parts of the body between active surveillance testing?
So if you go back to the PROTECT trial, which we talked about in the initial discussion, it's about 3%. So roughly, 3 to 4%. So it's a very low number, and people are like, well, I want to hear 0%. It's never 0%, but if you put in the context your risk of having a car accident or any type of accident or risk of death from cardiovascular disease or other causes of death, this is a very low number. Okay. So I think that, we all naturally just want to say there's no risk. There's always a little risk. There's a little risk if you drive home on a highway tonight, so but when you put it in the context of the risks of death and all the things that we're at risk for, it's a very low number. But even though it's low, that's why we follow you. So it's not like you have prostate cancer, it's low grade, see you, call me if there's a problem. No, it's you have prostate cancer, it's probably not going to spread, but I'm going to watch you for forever. And if it does change, we'll treat it. So I think a lot of times the way I describe active surveillance, it's timing of treatment. I'm not saying you don't need treatment ever. I'm saying right now, at the time or the consideration phase, you don't need treatment, but down the road you might. But I'm going to follow you so closely that if things change, we'll treat it, and we'll never be in a situation where we'll say, "Oh, geez, we should have treated that 3 years ago. We made a mistake." That doesn't happen based on the technologies that we have today.
Okay. And speaking of, that top technology, it's a good segue because the next question has to do with MRIs and what are your feelings about multi-parametric versus biparametric MRI?
Great question, a very technical question.
Yes, we have a
Multi-parametric
we have a good
is,
audience here.
yeah, well informed. That's why I love doing these. So biparametric MRI is basically an MRI that doesn't use contrast. A multi-parametric MRI uses contrast. There are three phases in a multi-parametric that we evaluate or use to look at prostate cancer. Non-parametric or biparametric doesn't use contrast and looks at it in two phases. I think the standard today is multi-parametric. Okay, the contrast, all the studies that we've performed are based on multi-parametric. That being said, there are studies looking at non-contrast biparametric MRI that show some promise, but I think the standard of care today would be multi-parametric. I think if there's an issue with contrast, allergies or things like that, biparametric would be adequate, but probably not the standard of care today.
Okay. Thank you for that. So I'm going to ask one last question. We've got a couple of questions about different tests. So, like genomic tests. So one mentions 4K score, but then I think more generally, let's step back. In talking about different genomic tests, and it probably depends on the test, but like what cutoff scores might someone look for? Just some guidance around these additional tests that can give us more information with active surveillance.
Sure. I think there's four products out today, okay? And they all have different cutoffs. But the beauty of these reports are they're very well written and they're very easy to look at. And they use, generally speaking, they're low risk, intermediate risk, or high risk. And they will actually give you predictive likelihood of spread of cancer, and some give predictive likelihood of death from prostate cancer. So my advice is go get those reports, ask for a copy of those reports, and you'll be surprised that how easy these reports are to read. And if you have any, stress or anxiety related to the reports, ask your urologist to go through it with them.
Yeah.
And you'll see that these reports are pretty easy to read and pretty easy to understand. To get into cutoffs, they vary from test to test. I think what I always say, and when I tell other urologists, is make sure that you order these tests to better identify patients that need to be treated and identify patients that don't need to be treated.
Dr. Hafron, thank you again. Thank you, attendees, and we hope you stick around for our next important session. Thank you.